Nobody give me, where's Jose so I can tell him? Don't give me crap about drinking water or not drinking water.
No, Jose's not even in class.
Yeah, I know. He's working.
Mm.
Yeah, he texted me on Wednesday that he was going to make it. All right. So anyway, so our patient has all of that. So what is that telling us? The stridor, the wheezing, weak rapid radial pulse.
Allergies?
Okay.
Respiratory distress.
Okay. So he has some sort of respiratory distress. And as far as allergies to what, Miss Claudia?
Mm, anything? I mean, medication, food.
Okay. So we're going to find out a little bit more in just a sec. The patient is unable to speak. With a history of bee sting allergy, a witnessed bee sting, and signs of severe distress associated with anaphylaxis, the EMT knows he must act quickly. So, does that confirm your suspicion?
Yes.
Okay. Following protocol, the EMT prepares to administer the epi auto-injector. So what is that medication?
The
What is
EpiPen?
epinephrine? Yeah. What does it contain?
Adrenaline.
Adrenaline, which is what? Classified as what?
Epinephrine, right?
Yeah, adrenaline is an epinephrine. Actually, epinephrine is adrenaline. But what is it classified as?
Narcotic.
Don't you be flipping me off, Claudia.
Oh, no, sorry.
See
No.
there holding that middle finger out. Actually, okay, now I know it. The technical classification is a sympathomimetic, which means that it mimics the sympathetic nervous system stimulation, but it stimulates alpha and beta receptor sites. Because remember we talked about alpha and betas?
Yes.
So it helps stimulate those receptor sites. Okay.
Hey Lou, can you repeat what made you confirm that it was an allergic reaction?
It says that he got that the patient has a history of he has a history of he's allergic to bee stings, and that somebody told you that he did in fact get stung by a bee.
Oh, okay. I didn't hear that.
All right. By what route will the EMT administer the medication?
What was that again?
What's the route that the EMT would administer the medication?
Like where or?
I am.
Yeah, the route is how it's administered.
Oh,
IM, IV, sub-Q, IN, ID, intradermal, IO, ET. So how is it administered?
I am.
What are the steps that the EMT must follow in administering the medication? And just think back to when I tested you guys out on it the other day.
Well,
Pull the little top. place it in the patient's hand, and then you count to 3, place it in the thigh area of the patient. Well, with their hand, you help them to place it in their thigh area for 10 seconds.
Well, it's more than just placing it there. Placing it is like I'm just putting it right, like
Oh no, they
placing it in
need
your
to
hand.
like make sure it goes in.
You inject it.
They bring it down onto their thigh.
Yes. Forcefully.
And then 10 seconds, and then you take it off, and then you
Kick
rub
your
it, no?
ass. Yeah, sure. I don't rub it. I don't. Usually when I give shots, I don't. I'll just wipe it down once if there's a drop of blood there, and then that's it.
Have you done it? How many times have you done it? I'm pretty sure you've done it.
EpiPen, none, but injections, a bunch. I can't
Oh.
tell you over the last 28 years, 28 plus years.
Oh, so the EpiPen, you haven't done it?
No. But then again, I don't need to give an EpiPen. All right, so frickin' dog, she frickin' sleeps all day, and then I come back from being outside, and then she gets up, and now wants to use the bathroom. Let me take her out. Hold on. Precious, vas a verlo. Allá quédate. ¿Cuándo íbamos a salir? No me va así. Ay, ¿quieres salir? Bótese. Bótese. No, I didn't hit her. You're frozen, or you're just like mad dogging me?
Ooh.
You.
What? No.
Yeah, you were just like, what the hell? No, as soon as I got up, she walked back to her little bed, makeshift bed. And I don't know if you heard me talking. So I was like, what the hell? So I kicked her out of the room, up in the door, and I walked towards it, and she walked out. So I locked it behind her. Okay. So moving on with drugs, with medications, they have the names. There's different 5 categories of names that every medication has. You little shit. Sorry. Siempre es igual cuando tenemos clase. Yeah. And of course, as soon as I open the door, she runs away towards the bathroom, and she just kept going to the kitchen. I'm like, okay. Well, actually, I gave her the choice, outside or to the room, and she went to the kitchen. So it's like, okay, never mind. Go to hell. All right, so 5 names. The first one is the chemical name. So it's basically the chemicals that make up the medication. And then you have the generic name, which is just the generic name is more of the there's a lot of air static or air noise coming from you. Yeah, it's gone, but I don't see why you're at the station. Anyway, so how can I put generic name? Generic name is a general name by which the medication is known for. So for example, acetaminophen. That's a generic name. Now, the trade name, also known as the brand name, is a name that is trademarked, that only the company that created that medication can use because they own the patent. They own the right to that name. So, for example, Tylenol. Tylenol is a brand name. No one else can produce Tylenol. They can produce acetaminophen, but they can't produce Tylenol. Same thing for like Viagra. Pfizer owns the name Viagra, but the generic name is sildenafil. Nobody else could make Viagra up until the time that, and this is with any medication, up until the time that the trademark ended for that company, and then once that, not trademark, the patent. Once that patent ends, then anybody can make sildenafil, or anybody can make acetaminophen, anybody can make diazepam. So that's the way to differentiate it. Another way to differentiate a brand name for a generic name is the brand name is the one that you got to pay like $600 to $1,000 for. Like one of my medicines, for a 3-month supply is like $1,700. And there's no other choice, although thankfully I don't have to pay that because my insurance covers it. But because it's still brand new, only one company makes that medication, so there's no competition. So they're able to charge, what is it, like almost $600 a bottle for a 30-day supply. And then the last name is the official name, and that official name is the name that it's registered under with what they call the United States Pharmacopoeia, which is the national formulary, just a list of medications that are out there. And the way you know that the trade name is, or I'm sorry, the official name, it is what it is because at the end you have USP. USP, again, standing for US Pharmacopoeia. Okay. So for example, for nitro, the chemical name is 1,2,3-propanteriol trinitrate. That's nitroglycerin. That's the chemical name. Whereas the generic name, excuse me, is nitroglycerin. While the trade name is nitrostat. And finally, the USP, the official name, is nitroglycerin tablets, USP. So there are different names for every medication. It's not just, oh, give me some aspirin, give me some albuterol. No, there's more to that. So again, albuterol, what do you think albuterol is? What do you think? Is that the generic name or is that the brand name?
That's the generic name.
That's a generic name. Yeah. Let's see. That's very high.
Is it working? Right now?
So you have a table that has common generic names, trade names, and what it's used for. So you see activated charcoal, the trade names, superchar, instachar, actidose, liquidchar. There, as you saw, albuterol is a generic name. You see trade names: Proventil, Ventolin, ProAir, Acuneb, Vospire. Then you have aspirin is a generic name, trade names: Bayer, aspirin, Ecotrin, Empirin, Bufferin. So, all right. So next up, we have the routes of administration. With the routes of administration is how the medication is administered, and in which way. Um, Now, the way that it's administered is going to affect how fast the medication is absorbed by the body and for us to be able to see the effects. Okay. Now, the way that we give them is made in such a way that it can get into the patient in the quickest way possible. So the common routes, we'll talk about each one individually, is sublingual, oral, inhalation, and then intramuscular or IM injection, intranasal, which is Narcan can be given intranasally, and finally subcutaneous or sub-Q injection, or even subcutaneous injection. So the first one is sublingual, and so as Ms. Claudia was talking about with the nitroglycerin, I give it to them in that little itty bitty tablet. And that's given sublingually because there's a lot of blood vessels underneath the tongue. And we want to make sure that it gets dissolved and gets into the bloodstream very, very quickly. Because why would we give nitroglycerin to a patient?
Are you asking why we would give it to him?
Yeah, why are we giving nitroglycerin to a patient?
If we hard
Block their arteries?
To block the arteries?
No,
To
like
open to
yeah,
up.
to
Open it.
open it.
the blood vessels.
Yeah, to open up the blood vessels. But what else?
For chest pain? For a patient
There
with
you
chest
go. Yeah, because the person's having chest pain. So do you think we want to stick around 20 minutes, see if that nitroglycerin worked? No, we don't.
No.
No.
And so it's getting circulated throughout the body a lot quicker, as opposed to going by way of the mouth. We only administer sublingual to alert patients because it has to go underneath the tongue. And like I told you guys last week, I'm not sticking my fingers Actually, it was this week. Huh?
You say it all the time.
True. I'm not. I'm not passing that teeth line. No way, no chance, no how. Okay. So the next route of administration is the oral route. With the oral route, that one is through the mouth. It is swallowed. It could be chewed as well, but it's going through the mouth, down the esophagus, into the stomach. Now, what happens with that is that it has to reach the stomach, and in that case, what's going to happen is we have to wait for the digestive tract to break it down, to get it absorbed in the bloodstream, and then start going through the body. And we call that third pass metabolism. So with that, that's where I came up with that 20 minutes. It takes about 20 minutes for it to start working. So do we have 20 minutes to wait? Maybe, maybe not. All right, same thing, only used in alert patients because they have to be able to swallow. And so medications such as activated charcoal, glucose, oral glucose, aspirin, activated charcoal, or where said that? Those have to go into the GI tract. Now, the body's not going to absorb the charcoal. It's just absorbing the poison, the substance that went in there, and then once it does, eventually it's going to get sent into the small intestine and eventually out into the toilet. So oral is by mouth. The next way is via inhalation. In other words, we have to inhale it. We have to breathe it in. And so those types of medications are gases and aerosols. Gases would be like oxygen. Aerosol would be like albuterol. So we breathe it in. It goes down into the respiratory tract, into the lungs, where eventually, as we've learned many times before, it gets in the alveoli. It crosses the barrier, goes into the capillary bed, and then it gets sent out to the rest of the circulatory system. All right, intramuscular injections. An intramuscular injection is given directly into the muscle. In order to do that, we have to use a needle. So, do people like needles?
No.
No, they don't. So, with that, although I always love how they talk about people with tattoos, and I've had it told to me before, they have tattoos and like, I'm afraid of needles. Well, then how the hell do you have a tattoo if you're afraid of needles? Well, it's different. No, it's not. This pain's only going to be temporary. That tattoos can be forever. It requires a needle. Again, it's gonna be a little uncomfortable initially. There is a technique. You saw the EpiPen administration. Try to get a meaty part of the thigh. But you could also give IM injections in the shoulder, the deltoid, or in the butt. Anything more than a cc needs to go into the butt. And it's just a matter of prepping the area. Alcohol prep pad, wipe the area, grab their butt cheek, pinch, inject, aspirate, inject, out. Done. Although with the EpiPen, yeah, same thing. Actually, you wouldn't prep it. Just inject it, big old needle. Narcan for a long time was injectable. But nowadays, again, you could buy it, go to local pharmacy and you could pick up Narcan. In that form, it's not where you have to prepare an injection or anything. That's given by into the nose, intranasal. There are some. Oh, I forgot to get that ready for you guys. There are some that. This is what I used to purchase for Speaking Rock, where it's it's single use. You put it in the nostril, and then there's a little button at the bottom, and you just squeeze that, and it goes into the nose. And the tip almost looks like the Flonase tip. It's a white plastic thing, goes up into the nose. You squeeze, and it's delivered into the nose. And then there's also others, and even if you do get the injectable kind or something, you could attach what they call a MAD device, mucosal aerosolized device, which looks like a triangle that you put at the tip of a syringe, and you put that up on the nostril and squeeze the plunger in, and then it mists it up and it delivers it to the nose. So, yeah, most likely EMTs are going to give the intranasal type. For that, it has to be in a mist form. You can't just get the liquid and shoot it up like when you get water up your nose, or somebody sprays water up your nose. Not the same thing. And then lastly, subcutaneous. Subcutaneous it goes into the subcutaneous layer, so it's also given by injection. It goes into the subcutaneous layer, and it's a lot slower than intramuscular injection. Now, because it's slower absorption, one trick that you could do is you could actually give a sub-Q injection of epinephrine, which you actually can. Some places, if you don't have the EpiPen, they'll teach you, and might teach you guys how to do subcutaneous epi. Depends on what kind of mood I'm in. You do sub-Q Narcan, and because it's slower, after they wake up from the intranasal Narcan, you give them a shot of sub-Q Narcan, and because it's absorbed slower, it's used to prolong the effect of the Narcan, so that way it doesn't wear off. Or it will, but it wears off a lot slowly. So hopefully by that time the drug has dissipated in their system. All right, questions?
Nope.
Okay. So medication forms. Medication forms is really the way that medication is made, and I don't say the production part of it so much as in how the product comes to be able to administer it. So, for example, does it come in a powder form or a tablet form? Like, what's the one that you dissolve? What's a powder that when you're sick, you dissolve it, you pour it, you open it up, you pour in water, you mix it up, and then you drink it?
No, is it amoxicillin? Is it
No.
the pink one? No.
There's some like that, but no. There's another one. No, it's for like when you have a cold or flu or something, or maybe
Alcohol. I can't say it.
Terraflu.
Alka
Yeah,
Seltzer.
is it Theraflu?
Yeah.
Well, yeah, it comes in a powder, and then you put the hot water in there, and then mix
Mm.
it up, and you drink it like a tea. Yeah, that would be like a powder. But then you also have compressed powder, and then you have the tablet.
Yeah.
All right, so tablet or pill form. So aspirin, and then you have liquid for injection. So the epinephrine and the EpiPen, that's a liquid form. And then you have the gel, which is like the oral glucose. It's a very viscous gel that is made sweet, and they also flavor it. So you have like grape, you have cherry, you have lemon. All right, the next one is suspension. Suspension is a mixture, or when you have mixtures of things, but they don't remain mixed. Okay. So the example of a suspension is the activated charcoal. Remember, you have the liquid, and then you have the charcoal. And so when it's put together, it does the job. You actually have to shake it up before you give it to the patient. If not, what happens? Then uh, that charcoal actually settles to the bottom, and all you have up on top is just the clear liquid. So you need to shake it up in order to combine it. And so when they drink it, now it's all ready to go. Okay. Um, Now another type is the fine powder for inhalation. So the albuterol in that inhaler, it's actually a very, very fine powder. Now you also have the liquid, but yeah, the fine powder is usually delivered by meter dose inhaler. And then you have the spacers that space out that inhaler. As far as the small volume nebulizer or just nebulizer, um, we're using a compressed gas to form that aerosol. So we're going to use the oxygen, attach it to the nebulizer, and then the oxygen is going to push into the chamber, and it's going to mist up that medication, and then the patient inhales those droplets. So you see, I don't know what table it is or whatever it is. But it could be either by the small volume nebulizer. There's two types. There's the handheld nebulizer, which is the one that the person holds in front of them, and they put the lips around the mouthpiece and they blow it through, which is what we showed you. And then you have a mask. I don't know if you guys got shown the mask as well, where you still have that reservoir container. You just attach it to a mask. What if you don't have?
Actually, Paul did show us the nebulizer because it's the one that you put the liquid in it and you
Yeah,
breathe it.
but he taught you wrong. He taught you wrong. Did I already talk about that with you guys?
No.
So walk me through. I'm an asthmatic and you're going to give me a nebulizer treatment. What are you going to do?
Help you. If you-
You're gonna unscrew it and pour the albuterol in there, and then screw it back on, and put the mask on, or give them the mouthpiece, and then turn it on.
How many bullets are you putting in there?
Two? I believe you said two.
Okay. Is it 2 bullets of albuterol?
I think it's a bullet of albuterol and a bullet of something else.
And that's what's wrong.
Or is it 2 of albuterol?
I've already talked to some in your class, and it wasn't 2 bullets of albuterol.
Okay.
You're right. The accepted dose now is 2 bullets of albuterol. However, follow your protocols. A lot of places are still using 1. But that second bullet that he mentioned was a bullet of sterile water. Am I right or am I wrong? You guys were all there.
I don't remember if he said sterile water. Like for our class, for my session, we just put 1 bullet of albuterol, but he said that you can put 2, but.
Okay.
Yeah, he didn't mention sterile water.
Or normal saline?
No.
No, not in our group.
Well, somebody tell me he did. I just want to make sure, okay? Because if you put anything other than albuterol or other than a duoneb, you're actually diluting the albuterol, and it's not going to be any good. Because I've talked to people that have said, "Oh yeah, you put 1 albuterol bullet and 1 saline bullet." No, you don't. Or sterile water. No, you don't. You're not giving them the correct concentration of oxygen or of medication. Said, "Oh yeah, you put 1 albuterol." So, okay. I just got to make sure of that. Okay. The other one is gas. So oxygen is a gas. It's the most common medication that we administer a patient, oxygen. Mm, mm, mm. And another type of nitro besides the tablet is also a spray. So nitroglycerin comes either in a tablet or a spray. Now, with the meter dose inhaler, before you administer it to, or you assist a patient with it, you need to shake it up. Nitroglycerin, on the other hand, you don't shake it up. Do not shake it up. And it's the same thing. It goes underneath their tongue, but because it's a spray, you still have them raise their tongue up, get it close to their tongue, and spray it inside their mouth, and then they close their mouth. Okay. Questions on the forms? A lot of information.
It's been worse.
Oh yeah, at the paramedic level, yeah. When I was in paramedic school, I had to learn 33 drugs and I had to memorize them. And then the quizzes, which is what I do to my advanced class, although I think there's cheaters and they work for elite. No, they really do work for elite, and I know they cheat. I just haven't caught them. So just keep an eye on those, at least 2. But no, I was given a blank sheet of paper and I had to write everything down about that drug. Actions, and this is what we're talking about: actions, interactions, contraindications, adverse effects, the dosage, how supplied, any special notes, indications, contraindications, the dosages, the administration, actions, side effects, or adverse effects, all that good stuff. So that's what we're talking about. You have to understand, number one, these terms, but you also have to understand that for each medication that you put into a body. Because for the most part, once you give a medicine, you can't take it back. So the first term is indication. What is it indicated for? So nitroglycerin, what do you think the indication is?
Chest pain.
Exactly. So an indication is the common use of that drug when you're treating that specific condition. So remember earlier we talked about also oxygen. What's the indication for oxygen?
Trouble breathing.
Trouble breathing, low pulse ox, trauma. So those are indications. And usually the indication is we're trying to give that medicine to kind of relieving the signs, symptoms, or that specific condition. So if somebody's having asthma, indication is bronchospasms. And so why do we give albuterol for the bronchospasms?
To
Leave the bronchodilator.
dilate
Is
the.
it open up the bronchioles?
Yes, ma'am. Yes, sir. All right. So now the opposite of indication is a contraindication. When do not give something because it could actually cause harm.
When there's no signs, or those
There
when there are not
Well,
those.
in a way, when there's no signs of it, but it's more of if there's another condition present. So, for example, nitroglycerin. Contraindication of giving nitroglycerin would be
Someone who's taken Viagra.
yes, on any of the erectile dysfunction drugs. Another contraindication of nitro is a head trauma or hypotension when their blood pressure is under 90 systolic. Because what can nitro do to the blood pressure?
Bring it down.
Drop it.
It drops it. So if it's already low to begin with and you give nitro, you just dropped it even more. And now what's happening to the perfusion in the brain? It's gone down. So next up is the dose. How much of a medicine do you give? So what's the dose of oxygen?
100 cc's.
What?
15 liters?
I couldn't hear you.
It depends. It starts at 1, and it depends on whether it's going to be by nasal cannula or by mask.
Okay, it starts at 1 what?
1 liter,
There you go. Up to?
6 liters by nasal cannula,
Just give me a broad range right now.
1 to 6, or 7.
Right now, all I care about is between 1 and 15 liters,
Okay. 1 to-
depending on the deliveries, on the delivery device.
okay.
Okay. So I think, Claudia, you said 500 cc's. And that's the tidal volume when we breathe in. Is that what you had said, 500 cc's?
Sorry, yes, I got confused.
Yeah, no worries. Yeah, yeah, that's the amount. We're just talking about liter flow on oxygen for it, but no, you're right. That's how much tidal volume we need on an adult. What's the dose for nitroglycerin? Actually, no, I take that back. What's the dose for epinephrine?
Well, for an adult is 3.3.
No, you were right initially.
What?
You started off right.
What do you mean?
You started to give me. You started saying 0, and then you changed it.
Oh,
I'm saying you started.
0.3.
Yes.
Okay, and then for pediatric is 0.15.
0.15. Okay. Yeah. Whenever you have decimals and there's no number in front of it, put a 0 in front of it. Okay. Especially in your documentation, 0.15 milligrams. And remember, always give the dose and the route. Okay. Always give the dose and the route. So 0.3 milligrams
Mhm.
IM, 0.15 milligrams IM. And this is of epinephrine. Okay. So that's a dose, the amount of drug that it is given. Now the next one is the route of administration, how you give it. And so what routes did we talk about earlier?
Sublingual.
Intranasal,
Subcutaneous.
inhalation, oral.
Liquid.
Okay. Claudia, don't talk to Adam until he sells me my gun back.
That's not Adam.
Oh, I look like Adam from here. Still, don't talk to Adam till he sells me my gun back.
No, that's Rudy.
Oh, I don't know, man. Now the actions. The action of a medication is what it does to the body. So the action would be it has two types of action. The therapeutic effect, in other words, is it doing the intended positive response to the body, what we're hoping for? But also there's the mechanism of action as far as an action of what it's doing. So in other words, with albuterol, we know that it's a bronchodilator, right? So as far as the mechanism of action goes, what is it that we're hoping to achieve? I'm sorry, I take that back. How does the drug work on the body?
Opens up the bronchioles.
Okay, so it relaxes bronchial smooth muscle. That is the technical action of albuterol. The classification actually of albuterol is it's a beta 2 agonist. So it stimulates and promotes beta 2 receptors. Okay, or it goes in there. So it's a beta 2 agonist. The action is it relaxes bronchial smooth muscle. Now, as far as the therapeutic effect goes, what are we hoping to do?
Help breathing.
How?
By
Yeah, we want it to improve breathing, but how do we want to achieve that goal? You said it before I started going off on the bronchial smooth muscle or relaxation of bronchial smooth muscle.
by opening
But-
the bronchioles?
Yeah, exactly, by opening up the bronchioles. So that's the therapeutic effect, is it opens the bronchial smooth muscles, letting the patient breathe easier. Okay. And then the last thing is side effects or adverse reactions. Same thing. Side effects are the undesired effects that that medication can cause. Doesn't necessarily mean that it's going to cause it. It's just what it can cause. So, for example, we talked about nitro. What's the side effect of nitro?
Lightheaded or
No, it's something that we mentioned a few minutes ago.
lowers blood pressure?
There you go. Hypotension is the side effect of it. The other thing is that yes, it can cause a headache because of the vasodilation that it causes. Most of them have a side effect of nausea and vomiting. So if somebody says, "Oh, I have a headache now," or "I have a headache," and I didn't have a headache before, and you just assisted them with their nitro, what can you tell them?
This is a
It's
side effect.
The side effect. Okay, it's a normal response to taking nitroglycerin. Now, the side effects can be predictable or they can be unpredictable. Okay. Did you guys want to take another break?
No, I'm okay.
I'm good.
I'm okay too.
Me too.
All right. Key steps to administer medication. So you want to you want to administer or assist a patient in administering a medication. What must you have before you do that?
Medical direction.
You have to have medical direction. How can you obtain medical direction?
Can you have a standing order?
Okay, how can you obtain that standing order?
Calling them or your protocols?
There you go. Protocols is the most common way to have a standing order. You can contact medical direction and get a verbal order, and remember that online and offline medical control. All right,
Yeah.
so you have the order. Now, the next thing you have to do is you have to pick the right medication. So one, learn what the containers look like, but two, you have to make sure you look at the name. Make sure it's a medication that you want. As EMTs, there may be some drugs you can give that they don't have themselves, but for the most part, you can only assist a patient in self-administering their own medication. In other words, it has to be prescribed to them. Okay, it has to be prescribed to them. They can't bring out their wives' nitro if they're having chest pain. It has to be prescribed to them. The other thing you have to do is check the expiration date of that medication. Now, just so you understand expiration dates, just because, let's say, today's June 5th, the medication expired May 31st. Did it magically lose all its potency and now it's like, oh, well, it's expired?
No.
No,
No.
it just got weaker.
Well, over time it does, but not on that magical day.
Okay.
It's just more of a guideline as to when the medication is really potent. As the time progresses, it does get weaker. Uh-huh.
Hi. Can you hear me?
Yes.
What's going on?
Sorry. So expiration dates, we do follow them in EMS because I wouldn't say it's an ethical issue, but it kind of is. We don't want to give our patients expired medications unless it's absolutely necessary. Okay. There's a shortage of a lot of medications, so we're still carrying, and this is all over EMS. We still carry expired drugs, but the medical director has to approve it. Sometimes you have to send a sample out to a lab, and they check the efficacy of it to make sure it's still potent enough to be administered. So yeah, just because it's a few days past the expiration date doesn't mean that it's not any good. And I tell you that for your own knowledge. So if you have like Tylenol that expired a couple months ago, no, it's still good. Now, if it expired 5 years ago, yeah, throw that out. Okay, yeah, it's not going to still be good 5 years later. Okay. So you look at the medication, make sure that it still looks normal. For clear liquids, make sure that there's no floaties in there, that it's still the same color. Most medications in liquid form come in a clear color. Granted, there's some like elixirs that come like red, purple, yellow. But for the most part, other medications are for the most part clear. So if they appear yellowish or cloudy, they're probably not any good anymore, most likely. So don't use it. And then make sure you know how it comes, the form, the dosage, and the dosage that you have to give, and how you're going to give that medicine. They talk about checking the 5 rights: the right drug, or the right patient, the right drug, the right date, the right time, the right documentation. I think that's what it is. And it's just making sure it's the right patient, that the right date is the right expiration date. It's not expired. Time, you write down the time, that you document that you administered or self-administered. You assist the patient in self-administering that medication. I don't use the 5 rights, and some books talk about the 6 rights. I use a different acronym, which is called, it's dicing a drug. So I check it's DICE, dice. So checking the drug, the integrity of the container, make sure it's not broken, there's no leaks, the clarity of the medication, and then the concentration of the medication. Because as a paramedic, I might not have to give the entire thing. Like I drew up 5 milligrams of midazolam for a seizure patient, but I only used 3 milligrams. So I had to know, based on the syringe, how much I had to give to get that 3 milligrams.
So when we write all that down, we have to give it to when we take the patient to the hospital, we have to, and you said we have to write everything down. Do we give that what we wrote to the doctor or whoever?
You do have to write it up, and if you have a paper form of the PCR, then you need to leave a copy with them, or they have to get a copy within 24 hours. So technically, the answer is yes.
Okay. And we keep like somewhat of what we wrote for our report.
Well, what do you mean? I think I know what you mean, but I just
okay. So
want to
we do a report for each patient, right?
You do
And
up
we
a
have
PCR.
to write what we did to each patient or whatever. So we have to give the information to the hospital, and then we keep the same information for our report. right?
Yeah, but it's the same report. So usually they're in like duplicate form or triplicate form.
Mm.
So you write out your documentation, you have them sign it, you tear off a copy, you give it to them.
Okay.
Or if you don't have it finished, state law says that you have to submit documentation, or the documentation has to be submitted to the hospital within 24 hours. So if you didn't happen to finish your report there, which you should try and finish your report at the hospital, but for whatever reason you didn't, you take it back to the station, then you finish it up, or finish up the next morning before you're off shift, and leave it there, and then they'll take care of scanning it and submitting it to the hospital for their records.
Okay. All right.
And then once you administer the medication, document that, like I said, document that you did assist the patient in administering, or that you administered that medication. Document the drug, the dose, and the route, and the time, at what time you gave it. Now, you guys are my medical direction, and I'm calling to see if I could assist them with the albuterol treatment. Their inhaler's not working, and they're really tight, and we happen to carry, and so I want to make sure. And so I call, or actually, yeah. So I call you guys, and I don't quite understand the order. You came in garbled. What should I do?
Repeat it.
All right. You want to repeat back the order. You always repeat the order back anyway. But this is why, in case you didn't understand them, then you're repeating it anyway. So yeah, always repeat back the order. Make sure when you are looking at the medication, you do look at it. What I was taught and what I teach is check a medication at least 3 times. So you should do the same thing. Look at it, kind of review it, the dicing it when you first pick it out. Dice it as you begin to prepare it, and then dice it again right before you give it to the patient. All right. So the 5 rights, the right patient, right medication, right route, right dose, right time. See, I don't know. I think I remember learning the 5 routes 23 years ago, almost 23 years ago. So I don't remember that, but I can remember a definition from 20 years ago. Funny, huh? Oh, another thing you want to document after you, besides that you gave it X time, is also the patient's response to that medication. You could write it positive, you could write negative, you could write down no change, you could write down patient began breathing easier after administration of oxygen. But document what their response to that medication was. So I just gave Andrew medication. Am I going to be like, okay, done. I'll be back over here napping, waiting for it till we get there?
No.
No. What must we do?
Reassess.
Reassess. Remember, we're reassessing our interventions. Was the medication an intervention?
Yes.
Yeah, when we administer medication, that's an intervention that we did. So what might we want to reassess of that intervention?
How they're responding to it?
Okay, good.
If it worked. Any side effects for the medication?
Okay. As far as that, did it work? We kind of did that with the response to treatment. But the side effects, yeah, you could write it down in your narrative. Patient began complaining of a headache after nitroglycerin administration. Recheck their vitals. Because again, nitro could do what?
Lower your blood pressure.
Lower your blood pressure. And we could assist with up to 3 nitros. And so
Ahorita
in
te-
order to give, what was that? In order to give another nitro, what must we be sure of?
That his blood pressure isn't too low?
Exactly that. His blood pressure is still good for us to give it. Now, for nitroglycerin, when you take National Registry, know that National Registry follows the American Heart Association guidelines to nitroglycerin administration. And the American Heart Association says the blood pressure needs to be at least 90 systolic, the top number, at least 90 systolic. Oh, that's what I was going to do with you guys today. Okay. I'm going to do 2 things with you. Here, I thought I'd have an early night. I'm not that lucky. So you have to make sure that your blood pressure is at least 90 systolic. Okay. Now, yes, protocols might be different, but for testing purposes, remember 90 systolic. Okay. Mm. All right. As far as sources, there's a lot of different sources out there, and there's even some available on apps. There's one that I like. It is free, and it's a very good resource. It's called Hippocrates. Epocrates. Hippocrates. Download that. It gives you a lot of information about different medications. Some of poison control centers, but that's more if a person is overdosing on something, or they try to commit suicide with pills. You can get information on that. But some of the others that the book talks about, they're expensive. Like the PDR, that's a huge price to be able to have a subscription to the PDR. So I don't recommend that. Hippocrates is pretty good. There's another one that I use called MPR, Monthly Prescribing Reference, but that's more for prescription for providers, advanced providers. But I like that one too. But check out Hippocrates. It's a great little app. Again, it's free. They have additional content that you can pay for, but you don't really need it. The reason I talk about that is because you can go on a call and the patient is suffering from whatever disorder, disease, whatever, and you see their medications and you ask them, do you have any medical problems? No. Do you take any medicines? Yeah, I take this and this and this and this and this. Like, oh my gosh, really? By using one of these apps like Hippocrates, you can look up a medication and it will tell you what it's used for. Now, let me give you an example. You show up on a call and the patient is a 28-year-old male that is altered, breathing at a rate of 10 times a minute. No, let's say 8. Let's say 8. And the roommate's there and they're like, I don't know. I know he's been sick lately. He went to the doctor. Do you know what they gave him? No, but his meds are over here. Or his medicines are over here. Okay. Off the top of your head, anything come to mind that might be wrong with him?
Okay, he's breathing how, you said? Or what's wrong with him?
8 times a minute.
Okay.
And he's actually he's unresponsive. So what would you do?
Check his airway and begin ventilation
How?
with the BVM.
Okay.
Unresponsive, check his pulse.
Yeah, it's the pulse.
Well, the ABCs.
You would
And then
check for blockage or obstruction, like vomit or whatever.
There isn't.
So then you would do the chin tilt
Head
and
tilt,
start an
lift.
airway. Yeah, and then
Claudia already took care of the ABCs.
okay, so then you begin one.
then you go see his medicine. What has he been taking?
All right. Did anybody ever think to ask about vital signs or take vital signs? All right. He's only taking one medicine. It's called Lomotil. Lomotil.
What was the name of it?
Lomotil. Lomotil.
MOT. Belongs to a class medication called antidiarrheals. It contains two active and atrophy. Euphoria, depression, confusion, dizziness, headache, loss of appetite.
What's the classification? It's an antidiarrheal.
Yeah. Yes,
But
sir.
what else? What else does it have?
It contains two active drugs. I don't know if I'm gonna pronounce them right. Atropine.
Atropine.
Okay, and
Is it atropine?
yes, ATROPINE,
Yeah, that's atropine.
and then diphennoxylate, DIPHENOXYLATE.
That phenoxylate.
Yeah.
So let me tell you this. It's a Schedule 5 drug. It also causes respiratory depression. Lomotil is actually a narcotic.
What I'm reading, it says that, hold on, it's so hot in here. There's like actually warnings for it. Lomotil warnings. Needs to be used with special caution, well, in children younger than 2,
Mm-hmm.
as overdose can result in severe breathing problems. Oh, okay. Oh, cool. All right, sorry.
That's all right. Narcotics. So the pupils will pinpoint. And by having a reference like that, that could help you determine what's wrong with your patient. There's other times that, like, there was one that I kept hearing about the other day, and it's like, okay, what is it? Lexapro. It's like, what's that for? Come find out it's a psych med.
And then this one, what's the medication that you said? Liquid, let me see. The liquid forms of this product may contain alcohol. Caution is advised if you have alcohol dependence or liver disease.
Because of the alcohol.
Yeah.
Mm-hmm. Yep. So if you're unsure of a medication, it's okay. I still look up medications. I've been doing this a long time, and I'm familiar with a lot of medicines. I used to work in a medical clinic with a primary care physician, an internist. So we used to see dozen patients a day, and actually had several different physicians in one office. So I've come across a lot of medications over the years. So I'm familiar with a bunch of them. Some of the newer ones, not so much, because I don't work in that anymore in the clinical setting. So it's just kind of what I might see on TV and stuff. But they still have a lot of the same ones. So a lot of information, a lot of different medications. So it's a good idea to kind of have something available. And there's nothing wrong if you have to pull out your phone to look up information. I had an overdose, which was attempted suicide. And I saw the meds, but I couldn't tell you how to take care of them. And it was an overdose or possible overdose. So I used my phone to call Poison Control Center. And I said, patient took this. She says it's approximately this many. And what do I need to worry about? And they just said, make sure she stays awake. Okay. Ran her over to the hospital, and that was it. So there's no shame in it. You know, I do it. So, all right. Let me get a couple things going for you. It's still going to be an early night.
You know someone who takes prescription opioids like
Could you hear that?
Percocet or Oxycontin, or illegal opioids like heroin, then you should know about the risk of an accidental, life-threatening opioid overdose. In fact, over 56% of overdoses happen in private homes beyond the immediate reach of doctors and nurses. There's a way for you to help someone who is experiencing an opioid overdose, even if you don't have specialized medical training. In this video are instructions for use, as well as the uses and safety information you should know for using Narcan. But first, it's important to be able to recognize the signs of an overdose. Signs of an opioid overdose include not waking up or responding to your voice or touch, breathing that is very slow, irregular, or has even stopped. The dark center part of the eyes becomes very small, sometimes called pinpoint pupils. Fingernails and lips turn blue or purple, a slow heartbeat, weak pulse, or low blood pressure. If someone has these signs, here's how you can help. Narcan nasal spray is a medicine that reverses the effects of an opioid overdose. Narcan nasal spray is not a substitute for emergency medical care. Repeated doses may be necessary. As with any drug, you need to be aware of important safety information about its use. Please pay particular attention to the indications and important safety information at the end of this video. Also, please see the accompanying full prescribing information in the use of this product. Narcan nasal spray was designed for use wherever an emergency opioid overdose happens. Because it doesn't require specialized medical training, it can be given to someone by following these instructions. First, lay the person on their back. Then, remove the device from the box and peel back the package. Hold the device with your thumb on the bottom of the plunger and 2 fingers on either side of the nozzle. Tilt the person's head back and provide support under their neck with your hand. Place and hold the tip of the nozzle in one nostril until your fingers touch the bottom of their nose. Press the plunger firmly to give the dose into the person's nose. After giving the dose, remove the device from the person's nostril and move them on their side, positioning their hands under their head. Call 911 and get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan is not a substitute for emergency medical care. Keep the person under observation. If the person doesn't respond by waking up to voice or touch or breathing normally after 2 to 3 minutes, administer the second dose provided in the box in the alternate nostril. If they respond and the signs of an opioid emergency have returned after Narcan nasal spray is given, then give another dose in the alternate nostril using a new device and watch them closely until emergency help is received. Additional doses may be given every 2 to 3 minutes until they respond or emergency medical help is received. After using Narcan nasal spray, put the device in its box and then dispose in a place safe from children. Narcan nasal spray delivers a consistent, concentrated 4 mg dose of naloxone that can reverse the effects of a life-threatening opioid overdose in minutes. Visit Narcan.com to learn more. There's a way for you to help someone who is experiencing an opioid overdose, even if you don't have specialized medical training. Indications and important safety information. What is Narcan nasal spray? Narcan nasal spray is a prescription medicine used for the treatment of an opioid emergency, such as an overdose or a possible opioid overdose with signs of breathing problems and severe sleepiness or not being able to respond. Narcan nasal spray is to be given right away and does not take the place of emergency medical care. Get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan nasal spray is safe and effective in children for known or suspected opioid overdose. What is the most important information I should know about Narcan nasal spray? Narcan nasal spray is used to temporarily reverse the effects of opioid medicines. The medicine in Narcan nasal spray has no effect in people who are not taking opioid medicines. Always carry Narcan nasal spray with you in case of an opioid emergency. Use Narcan nasal spray right away if you or your caregiver think signs or symptoms of an opioid emergency are present, even if you are not sure, because an opioid emergency can cause severe injury or death. Signs and symptoms of an opioid emergency may include unusual sleepiness and you are not able to awaken the person with a loud voice or by rubbing firmly on the middle of their chest, breathing problems, including slow or shallow breathing and someone difficult to awaken or who looks like they are not breathing. The black circle in the center of the colored part of the eye is very small, sometimes called pinpoint pupils, and someone difficult to awaken. Family members, caregivers, or other people who may have to use Narcan nasal spray in an opioid emergency should know where Narcan nasal spray is stored and how to give Narcan nasal spray before an opioid emergency happens. Get emergency medical help right away after giving the first dose of Narcan nasal spray. Rescue breathing, or CPR, may be given while waiting for emergency medical help. The signs and symptoms of an opioid emergency can return after Narcan nasal spray is given. If this happens, happens, give another dose after 2 to 3 minutes using a new Narcan nasal spray, and watch the person until emergency help is received. Who should not use Narcan nasal spray? Do not use Narcan nasal spray if you are allergic to naloxone hydrochloride or any of the ingredients in Narcan nasal spray. What should I tell my healthcare provider before using Narcan nasal spray? Before using Narcan nasal spray, tell your healthcare provider about all of your medical conditions, including if you have heart problems, are pregnant or plan to become pregnant. Use of Narcan nasal spray may cause withdrawal symptoms in your unborn baby. Your unborn baby should be examined by a healthcare provider right away after you use Narcan nasal spray. Are breastfeeding or plan to breastfeed? It is not known if Narcan nasal spray passes into your breast milk. Tell your healthcare provider about the medicines you take, including prescription and over-the-counter medicines, vitamins, and herbal supplements. What are the possible side effects of Narcan nasal spray? Narcan nasal spray may cause serious side effects, including sudden opioid withdrawal symptoms. In someone who has been using opioids regularly, opioid withdrawal symptoms can happen suddenly after receiving Narcan nasal spray and may include body aches, diarrhea, increased heart rate, fever, runny nose, sneezing, goosebumps, sweating, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, stomach cramping, weakness, increased blood pressure. In infants under 4 weeks old who have been receiving opioids regularly, sudden opioid withdrawal may be life-threatening if not treated the right way. Signs and symptoms include seizures, crying.
He was boring me. There's something real quick kind of related to that. So since we're talking about medications today, I wanted to share this with you guys. Hopefully you guys will get a kick out of it. Wait.
Very much. Man, it is so cool to be back together with these guys doing this, you know? I
You guys hear it?
Yes.
Yes. Yes.
I love that video. And again, since we're talking about side effects today, I love that skit. All right. The next thing I want to show you guys, let me find it. There's gonna be a couple videos. The biggest obstacle, or actually, there's two obstacles you guys have to overcome. The first obstacle is National Registry. The second obstacle you have to overcome is yourselves. We are our own worst enemy. Some of you get test anxiety, and there's that assessment on EMS testing for test anxiety. Get out of your heads. National Registry is passable. Okay, it is passable. I can tell you people that have taken registry and they're dumbasses, and they're horrible. They're too robotic. They don't have really what it takes. And then there's people that have it, but they can't pass registry. First off, because of the confidence level. So those are the two obstacles. Okay. So let me load it real quick. Mm, 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 mm. I'm just debating whether I should show you a 20-minute video or not. Okay, so this is digesting a question. And this is exactly what I try to do with you guys. So I don't do it for my health. I think I've told you, I hate reviewing questions. Although you guys aren't as bad as previous classes or like with Myra when she was in class. I just don't like to review. But I do because I want you guys to understand why the answer is what it is. Okay. So this is one of my colleagues. His name is Dan Limmer. I think I've told you. He writes textbooks also. He teaches EMS. He's been in EMS for a long time. He also writes one of the EMT textbooks. Very knowledgeable guy, really nice guy. I learned stuff sitting in on a class he did at a conference a couple of years ago. So it was a great class. So.
Hi,
Can you
this
hear
is
him?
Dan Limmer from Limmer Creative. I'd like to talk to you in this video about how to
Can you hear him?
Yes. Yes.
Yes.
Okay.
Yes.
Just making sure. All right, here it goes.
digest a test question. Now, when I say digest, I mean, how do you read the question, really understand what it's asking, and let that lead you to the correct answer? That's what this is about. And I think one of the best ways to start is to read the entire question and the choices before you make any decisions. Just read the whole thing. You should start with that intent. It's information gathering. Let's do that. I have a 56-year-old male patient complaining of chest pain and respiratory distress. Patient has prescribed nitro and an albuterol inhaler. He doesn't know if he has allergies. You hear inspiratory rales. The pulse ox reads 92% on room air, and the vitals are heart rate 102, respiration 16, blood pressure in a sitting position is 98/60. So which of the following medications would be the least appropriate for the patient? Aspirin, oxygen, albuterol, or nitroglycerin? All right, we've looked at the question. Now let's go back. We've got a sense for it because this is important now. What's the least appropriate? So which one of the four choices is the least appropriate? Which one are we least likely to give? So let's go back to the top. It's a 56-year-old male. Now that's probably not the biggest piece of information you'll get out of this question, but it is different than a 26-year-old male or a 16-year-old male. A 56-year-old male is an age when there certainly could be issues going on because he complains of chest pain and respiratory distress. Certainly is common that they're together. And since he has prescribed nitroglycerin, he probably has a cardiac condition of some sort, and he has albuterol inhaler, which means that he has a respiratory condition of some sort. Now, if I were to look at that just as an experienced person, I'd say, well, albuterol inhaler could be a couple things. One, it could be asthma. He may have had it for a while. Or maybe he smoked since he was a young, teenager, or had a environmental exposure through work, industrial exposure, and maybe he's starting some COPD. But he's got two medications that are used for two different things. He doesn't know if he has allergies. All right. He has rales. Rales indicate fluid in the lower airways, and his pulse ox is 92%. So just from this, well, I say we know this. AHA says 92%. Oxygen's okay. There'd be a lot of times that we might not give any oxygen, but at 92%, I think we'd give oxygen. I believe that's clinically appropriate, so I'm going to take that out of my choices. And since he has rales, and rales generally indicate the cardiac problem, probably some heart failure. Now, if these were wheezes, I'd say maybe it's respiratory. But those rales kind of lead me towards cardiac. So with chest pain, cardiac cause, we don't know about any allergies, I'm going to take aspirin off the list. That leaves me with two choices. Many times a test question will go this way. So which one is least appropriate, the albuterol or the nitroglycerin? Well, based on this, what we said with the rales, if this in fact is a cardiac origin, then the nitroglycerin would be appropriate. Now I know what you're thinking. Hold on a minute, Limmer. 98/60? Can I give nitroglycerin if the systolic is 98? Now, here's what everybody says. My protocols say 100 or 110 or 120 millimeters of mercury systolic. Here's the thing. The National Registry will not go by your protocols. It won't go by anybody's protocols. It's a national exam. Do you know the package insert for nitroglycerin says don't give nitroglycerin if the blood pressure is below 90 millimeters of mercury? So this might be clinically okay. But here's the other thing. Albuterol, they have rails. Remember how I said earlier, if that said wheezes, that's what albuterol can fix. Albuterol will help open up some of those small, narrowed airways, and that will stop the wheezing. But it's not wheezing, it's rails, it's heart failure, and it's cardiac. So here's the question. Here's what this really, really boils down to. If you were to read this and digest it and interpret it well, the question is, do I give the medication that's not indicated, that would be albuterol, or the medication that's borderline based on the blood pressure? Because one thing I will tell you about the blood pressure, he's in a sitting position. He appears to be able to answer questions, so that seems okay. Now his pulse pressure, the difference between the systolic and the diastolic, is 38. That's actually a pretty good pulse pressure. It's not narrowed. It doesn't indicate shock by any means. So by digesting this question, I would say that nitroglycerin is appropriate. The least appropriate in the choice that I would make here is albuterol. Now, I know a lot of you are freaking out. You're going to say, I could never pick that. My instructor said never give nitroglycerin. You know what? The National Registry doesn't listen to your instructor or your protocols. It's about reading the question. Now, if you've talked to anybody who's taken the registry, or probably your instructor's told you this, there are times that you'll get questioned with 4 answers, and they're all horrible choices. Or you'll get 4 answers, and you say, holy cow, I think they're all right. So in this case, we took a couple out, but we had a couple that really had 2 choices left that we had to try and figure out. You need to find, sometimes they're subtle. You need to go through and be able to read the question. And you know what? You do have time for this. They give 2 hours, 120 minutes. And a lot of people get through the National Registry in 60, 70, 80 questions, which means you got a ton of time. The average time a student takes is just a little more than 30 seconds. So you have the time, if you have a challenging question, to take a look at it. Now I want to tell you one more thing. No one gets 100% on the registry. Even if you're a student that in class gets high 90s on all the quizzes and tests, the National Registry is most likely a different kind of exam. If you get a tough question and you choose the best answer that you can after digesting the question, move on. Don't let it shake you. And it's just so important for you to remember that you're not going to get them all right. Do the best you can. Read it, figure out what the question is really asking, narrow it down as best you can, make a good choice, and move on. You have the time. I think this was a really good example of a question that's challenging because the answer, you ruled out a couple, but there were 2 that made you say, which one is it? And neither of them you thought were great choices, but there was a reason why one was better. The blood pressure may have been borderline, but albuterol wasn't indicated. And that trumps everything. Why would you give a medication that's not indicated? All right, that's it. This has been Digesting a Test Question. This is Dan Limmer from Limmer Creative. Limmer Creative creates apps for classroom study.
So he does have an app, and actually, and I'll probably lump you guys into this other class too, so I don't have to reach out to her. But I have a flyer that I will email you guys, and that way you guys can get the app. It has questions. Have I done that with you guys yet?
No.
Let me show you guys real quick. So I've told you there's a lot of different resources out there that you guys could use, and this is one of the ones. And I learned about all this stuff when he presented at that conference. And I don't want that. Let's see. So that way you guys don't see my login info. Where are you at? Where are you guys hiding from me? That's not fair. Okay, so yeah. It's EMT Review Plus. And so you could study concepts, review concepts, and then you could take a test to review those concepts. So let's do a review. And we're going to review prep because we've done prep. Okay? So here's a question. So the suffix otomy means what? To close or suture, to heal, to remove, or to make an incision.
To make an incision.
Yes, ma'am. Next, if you're trying to find the jejunum, you would look in the what? Abdomen, urinary tract, brain, or the mediastinum?
Abdomen.
The spleen is located in the what quadrant?
All right, right upper.
Nope. The left upper. The Ryan-White Care Act does what? Forces patients to be tested when an EMT has been exposed to their bodily fluids, protects patients who have been exposed to disease by healthcare workers, helps emergency responders determine if they have been exposed to disease, or protects children against infectious diseases spread by adults.
Would it be the first one?
Would it be the last one?
All right, who's the tiebreaker? What do you think, Claudia?
The last one?
Oh,
Third
C.
one.
Oh.
It's not just children. Did I talk about the Ryan Care White Act? Or the
No.
Ryan White Care Act?
No.
It used to be in another edition of a book. You guys know who Ryan White was?
No.
Ryan White was a teenager in Florida. He lived in Florida. And he suffered from a disease called, what is it? Where they can't clot. Hemophilia. He suffered from hemophilia. And back in the day, back in the 80s, and back in even today, the way they treated them was giving him a blood transfusion. Well, he received a blood transfusion. Well, back in the early days of AIDS, they didn't test blood for AIDS or HIV. Excuse me. And so he acquired AIDS. Well, his big fight, and it wasn't just because he was a teenager with AIDS. It was because he was a teenager, and back then it was AIDS and HIV had a very bad stigma where it was a gay man's disease, and it was a death sentence. You didn't live very long with AIDS once you acquired AIDS. And so here's this teenage kid who's going to high school, and his classmates didn't want him anywhere near him because of AIDS. And so his story made the news. He befriended famous people such as Elizabeth Taylor, Michael Jackson, and Elton John. He ended up dying from AIDS several years later. And what eventually happened was they created this act. Well, what this act does, number one, it establishes a Ryan White liaison for different organizations. In other words, they're responsible for making sure that if an employee is exposed to a bodily fluid, that they get tested. Now, if anybody's ever been tested, I'm not going to ask, and I don't want to know, but if anyone's ever been tested for any type of STD, up to and including HIV, you have to give permission. They can't just test your blood just to test it. You have to give your permission, your consent for them to test your blood. Well, let's say I got stuck by a needle because Joe Blow over there was HIV positive, or I thought he was HIV positive. And he's like, no, I don't want you to test my blood. Well, then what would happen? Would I be worried about maybe getting HIV? Yeah. Now, if I said, well, I want his blood tested, could they test his blood?
Not without his consent.
Not without his consent. So I was SOL. So that's the other thing. Like I said, that's what the Ryan White Care Act did. Now, is allowed us to get that blood tested without their consent. Now, what you said, Vanessa, isn't it pretty much the same as C? Okay, for everybody else, don't A and C kind of say the same thing?
Yes.
Yes. However, A, isn't that a little bit more forceful?
Yes.
So why not choose something that's a little bit lighter, but it still gets the same result? Right? Does that make sense?
Mm-hmm.
Okay. So that's why C is the correct answer, because we're able to determine if we've been exposed to disease by having that blood tested or that individual tested. But we're not forcing them, although we are, but we're not, it doesn't sound as bad. So, all right, next. You and your partner have just finished a serious call involving a pediatric patient the same age as one of your partner's children. At the hospital, he is acting angry and is unable to focus. This reaction is mostly what? And this kind of sounds like a question you guys had on one of your exams, doesn't it?
Yeah.
So which one is the answer on this one?
A.
Okay.
Yes.
There you go. Because acute is sudden onset. It didn't say anything about him having any issues beforehand. Now, after the call is when he's having a sudden reaction. Cumulative stress is burnout. Delayed stress, you're going to see it days later. PTSD, no, it's not that. He's had 3 calls and blah, 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 something that would be a PTSD type of event. Okay. So anyway, so that's the app that's available. Like I said, it's great to review things, and then you could test yourself out. They have flashcards in the study. So right now, where are we at? Oh, we just did assessment. How long should you perform a carotid pulse check on an unresponsive patient? No less than 5, no more than 10, right? See, so you see how it's showing you the answer, and then you show the question again, and then repeat it. So, okay. So I can go on to the next one. What is referred pain? Okay, referred pain is felt at a location other than its source, such as, and this is just giving you an example. In cases of pancreatitis, pain is often felt in the shoulder. This is an example of referred pain. So all that you really need to know is, what is referred pain? Pain felt somewhere other than the source or other than the originating organ. So it's just, all it is flashcards. Okay. So going back to Dan and the video I showed you on the registry question. First off, did he tell you a lot of points that I've been telling you in the last 2 months?
Yes, he did.
Yeah. So if you hear from somebody else, maybe you'll be like, oh, maybe Lou really isn't so full of it. Right? No?
Yeah.
Yeah,
Yeah.
I still think that. So, but the other thing is, you see how you go through a question, and he even said it, know what the question is asking. Like I did this with my morning class the other day, and they're like, oh, I misread it because they didn't look at least. So that's why I know what the question is asking. Analyze that question. Okay. And in general, just look at it. So we are on our own worst enemy. That's an obstacle you have to overcome. Just breathe, relax. The information is getting into your head. Just read the question. And I know some of you worry about looking at the clock. We were talking about this on Wednesday. Don't look at the clock. On the average, people finish a question in 30 seconds. So you're accumulating time. Don't look at the clock. Okay. Do you guys have anything else for me? I don't have anything else for you guys.
No, sir.
No.
No, sir.
So I hope this stuff helped. Pharmacology will be at the school on Monday for pharmacology. I will have you guys playing with the nebulizers, with the inhalers. I'll have you guys. What else? I might even show you guys sub-Q epi. Okay. So, what else? So we'll keep the same groups, the same times. That seems to work. Anything else?
No, sir.
Nope.
No, thank you.
All righty.
All right. Thanks,
So,
Lou.
all right. So
Thank
you guys
you.
have a great weekend, and I will see you guys on Monday over at Pro Action.
See ya.
Good night.
Night.
Thank you.
Bye.
Good night.
Good night.